Welcome to Mental Health Mini number 23, where we'll talk about major depressive disorder. Major depressive disorder is one of the leading causes of disability in the United States, contributing to lost work hours as well as a significant amount of treatment. It does affect women 2 times more than it affects men and can be affecting 20 to 25 individuals at any given time, with that number increasing. We are especially seeing an increase in school-age children and teens following the pandemic. It is highest in individuals aged 45 and younger. However, we do see another spike of depression after the age of 75. It is more common in wealthier countries. There's no association with race, although we do see an association with geographical region. Areas with less sunlight and colder weather tend to have higher rates of depression, with the exception of countries that tend to eat more fish. It is more common in those who remain unmarried or are separated or divorced, and it is more common in fall or winter months. The diagnostic criteria for major depressive disorder based on the DSM-5 is that they have to have a number of symptoms, 5 or more of the following over a 2-week period, with one symptom being depressed mood or loss of interest in pleasure. The other symptoms that can contribute to that 5 or more can be weight loss or weight gain, insomnia or hypersomnia, psychomotor agitation or psychomotor retardation, which is just slowed movements, loss of energy, feelings of worthlessness or guilt, poor concentration and indecision, and recurrent thoughts of death and suicidal ideation. In order to be considered major depressive disorder, the symptoms must cause distress and impaired functioning either at work, in relationships, or in daily life, and it cannot be attributed to another disorder or substance use. Additional symptoms that we can see of depression include social isolation and withdrawn behavior, hallucinations and delusions, which can also be classified as loss of reality-based thinking, delayed speech, flat and monotone speech, frequent crying, denial, agitation, preoccupation with certain thoughts, rumination. We can see physical symptoms such as headaches, pain, nausea, and vomiting, poor ADLs, and decreased libido. Across the lifespan, we also see different presentations of major depressive disorder. In pediatrics, a lot of times the presentation is more somatic based. So they may have appetite changes, headaches, nausea, vomiting, upset stomach. They can also have increased tantrums, delayed speech and social development, phobias and anxiety, difficulties in school, poor self-esteem, and excessive worry. Once the individual reaches teenage years, the symptoms tend to present more similarly to what we would see in adults. In pediatrics, we're more reliant on therapy and less reliant on medications. However, we can use medications if needed. They would just be at a smaller dose. For our geriatric population, symptoms are often confused for a neurocognitive disorder like dementia. We do find that individuals that have multiple medical conditions or need extended healthcare services have a higher risk of developing depression. And we also see that depression rates may be higher in the geriatric population because they're starting to lose function. They may have financial difficulties. They may have a lot of discomfort, and they can have impending thoughts of their own death. In addition, they have social factors where a lot of their family, friends, and maybe significant others are starting to pass away, and they can develop what we call bereavement overload, which is too much grief at one time for them to handle. In addition, according to Erickson's stages of development, they're in that generativity stage where they're trying to determine the impact that they've had on society and the impact they have on people they know. And if they feel that they didn't quite live up to that, they can develop depressive symptoms as well. The thought behind how it develops is that there is a genetic component to major depressive disorder. It can develop from a deficiency in neurotransmitters such as norepinephrine, serotonin, dopamine, acetylcholine, and we're also finding that it may also be impacted by higher levels of melatonin. From a nutritional deficit standpoint, people may have a deficit in proteins, carbs, vitamin B, iron, zinc, calcium, chromium, iodine, lithium, selenium, or potassium contributing to depressive symptoms. As far as hormones go, we see that individuals with higher cortisol levels have more risk of depression, and those that have imbalances of thyroid hormones can also develop depression as well, especially those with hypothyroid. This model is called the transactional model of stress adaptation, and it's another theory as to how depression develops. And basically, it's focused on the individual's inability to cope with either a real or a perceived loss. So if someone has a real or perceived loss, they are going to use their prior experiences to try and comprehend that. If they have inadequate coping skills, lack of social support, neuroendocrine disturbances, or anything else that might increase depressive symptoms, then they enter cognitive appraisal, where they look at their thoughts, they look at their life, and they try and determine if it is a loss that's really as devastating as how they feel. Then they think about how that loss affects their self-esteem, and they may start to further diminish their coping ability, further diminish their self-esteem. They may start to use defense mechanisms, and then they have to either respond more adaptively, which would lead to uncomplicated bereavement, or maladaptively, where they can enter a stage of denial of loss, or they can enter a stage of depression. Secondary depression is often related to other causes, such as with substance abuse. Alcohol can cause symptoms of depression, especially as someone is withdrawing. Amphetamines and cocaine, as someone's coming down from it, they can experience severe depression symptoms. Hallucinogens can cause depression, as well as opioids, sedatives, and anxiolytics. Comorbid disorders can also cause depression. More commonly, we see it with individuals that have had a stroke, are diagnosed with a terminal illness, have an endocrine disorder, especially related to the thyroid, those that have neurodegenerative disorders such as dementia or delirium, and those that have had traumatic brain injuries. There's also a lot of medications that can cause depressive symptoms, such as anesthesia, pain medications, analgesics, anticholinergics, steroids, dermatologics, and oral contraceptives. When we're assessing someone that has major depressive disorder, we're going to assess 4 different domains. We're assessing their affective domain, which is their mood and how they show their mood. We're assessing their behavior, their thought process, and any physiological factors. There's a lot of different scales that we can use to assess somebody's risk of depression or their experience of depression as well. Most commonly, we'll just ask on a numeric scale. On a scale of 1 to 10, how depressed do you feel? We can also use the Hamilton Depression Scale or the Beck Depression Inventory. While there's a lot of other scales out there, those are the most commonly used in the healthcare setting. Nursing problems for an individual that has major depressive disorder can include risk for suicide, complicated grieving, ineffective coping, low self-esteem, powerlessness, social isolation, disturbed thought process, insomnia, anxiety, self-care deficits, and spiritual distress. Interventions that we can do is often in combination. So a lot of times we'll prescribe someone a medication such as an antidepressant, but we'll also give them therapy as well. So the common therapies that we can use for major depressive disorder include psychotherapy, cognitive behavioral therapy, helping them with goal setting and coping skills, and activity therapy. If a patient is placed on an antidepressant, keep in mind that it can take 4 to 6 weeks or 4 to 8 weeks for effectiveness, depending on the medication. From weeks 2 to 6, they are at an increased risk for suicidal ideation. This is because the individuals may have suicidal thoughts, but in the deepest stages of their depression, they don't have the focus or energy to carry out any plans. When they're placed on medications, those physical symptoms of energy and planning tend to improve before their mood improves. So suddenly they'll have the energy for it. So we do want to educate patients on that and monitor them during the initial phase of initiating a treatment. We also want to monitor for any medical emergencies or adverse effects. With antidepressants, this could be serotonin syndrome, hypertensive crisis, as well as things like weight gain that may be very distressing for the patients. We can also supplement an antidepressant with a mood stabilizer or an antipsychotic, depending on the severity of the individual's experience with depression and how they've responded to other medications. Additional medical interventions that we can do is electroconvulsive therapy, transcranial magnetic stimulation, and phototherapy. And then lastly, we would want to place the patient on suicide precautions if they're showing any indication of suicidal ideation or thoughts. This would include increased monitoring and removing any sharp objects or things that the individual can carry out their plan or that they could hurt themselves with. The evaluation for effective treatment for depression would be improvement in mood, no harm to self or others, improved hope, improved ability to perform ADLs, increased interest in activities, having a balanced nutrition, improved cognitive processes, orientation to reality, improved social satisfaction, and having adequate sleep. And that is our mental health mini on major depressive disorder.